takes glucose and sorted other things all through the body. The blood's like a messenger, okay? Carries away metabolic waste products, primarily carbon dioxide. Responsible for supplying and maintaining adequate blood flow. Your cardiovascular system is the heart and the blood vessels. Okay, this is an easy chapter. All right? You guys have already done this. You did this for your midterm. There's the blood flow of the heart. There's your superior vena cava, your inferior vena cava. They both go into the right atrium. Take care, Alex. Hope it goes soon.
Thank you.
You can just leave it like Alex.
Do I?
You can just leave it. I mean, you're sick. You can just leave it like that. You're sick. Into the right atrium. You drop through the tricuspid valve into the right ventricle. Okay? We come out of the right ventricle on the pulmonary artery, the only artery in the body to carry deoxygenated blood, but we call it an artery because arteries always carry blood away from the heart, to the lungs. And remember, it goes to those capillary beds that are all spider-webbed around your alveoli, and it picks up a load of oxygen, gives off its carbon dioxide, so now it comes out red. It's all oxygenated now. And we come back to the heart on the pulmonary veins. The only time that veins are carrying oxygenated blood, but we call them veins because they're coming towards the heart. We come into our left atria, down through the mitral valve, into the left ventricle, out of the left ventricle into the aorta. The aorta comes out right here. This is the aortic arch, and it comes down behind, the descending aorta, and then this is, puts blood up to the top of the body. And you guys have already done that. Like I say, this is all review. This is going to be an easy 100. All right?
Would they literally have anything on, like, that entire flow of the heart on the National Registry?
I don't know if they'd have the entire flow. What they might do is give you 4 choices. Right atria, mitral valve.
I like that question you had on
like
ours.
I had. They might do something like that.
okay.
I don't think they'll show a picture and say, Tracy, they'll give you some kind of, but they might mix it up. You might say, oh yes, it comes into the right atria. It goes through the mitral valve. It goes down into the right ventricle. Wait a minute, mitral valve. That's over here. They'll have one little slip up, okay? All right. So your cardiovascular system here is composed of 3 parts. The pump, which is the heart, pumps the blood around. The vessels, your arteries, veins, capillaries, that's the container. And the fluid, the blood, okay? That's your cardiovascular system. The heart, got to have a rich, well-distributed blood supply, or we run into a heart attack. Works as 2 paired pumps. Remember, the heart is basically split right down the middle, which is known as the septum. The middle of the heart is known as the septum. The right side of the heart is low pressure. It sends blood to your lungs. Left side of the heart is what has to force blood through the whole body. So that left ventricle is the most muscular, mighty part of the heart. Typically, it's where you have troubles, okay? It's where you'll have your heart attacks and stuff like that. Remember your upper chambers are the atria. That's plural, atrium is singular. Lower chambers are the ventricles, okay? Blood leaves each chamber through a one-way valve, okay? We come down from the atria through the tricuspid and mitral valves. And if you want to go into it slightly farther, your blood goes into the aorta. It goes through the aortic valve. It's kind of the gateway to the aorta. And it goes into your pulmonary artery through the pulmonic valve, kind of the gateway to the pulmonary artery, which goes to the lungs. These one-way valves, they keep the blood flowing in one direction, okay? There's the heart. Arteries, they always carry blood away from the heart. Arterioles, it says the arteries get smaller and smaller. At some point, they're known as arterioles. And then they come into the capillaries. So the artery is carrying this blood away from the heart, this oxygen-rich blood. And then it goes down into arterioles and then into the capillary beds, which are all through your body. Because it's at the capillary bed, sir.
So are the arterioles like the size of say this vein right here?
Probably smaller than those.
Probably smaller than those.
My guess is that's getting close to the microscopic level, but
Okay.
I'm guessing they're getting down somewhere in there, but I honestly don't know that answer.
Okay.
Your capillary beds are all through the body because it's in the capillaries, these tiny, thin blood vessels that the actual exchange of oxygen and carbon dioxide takes place. I mean, it's done at the alveoli, but the capillary beds that are over the alveoli. And all through the body, the capillaries give off oxygen to the cells and pick up carbon dioxide and give off nutrients to your cells, okay? That's all done through the thin-walled capillaries. Capillaries are so small that red blood cells can only go through them one cell at a time, like single file, and you can't see a red blood cell. That's how tiny capillaries are. You gotta use a microscope. All right, you got the same thing. You got your biggest veins, the superior and inferior vena cava, and then goes down to smaller veins till you get to venules, and that's what comes out the other side of your capillaries. The arterioles, carry the good blood, clean, oxygen-laden blood into the capillaries. Then we come out on the venules.
Excuse me.
Yes.
So, exactly what part is the septum? Where is it?
Oh, okay.
I can't see
All
it.
right. Here we go. I'll show you on this big thing right here. This is the septum. This right here.
Okay, okay.
It's the wall of the heart that divides the heart into right and left. Just comes right up the middle. Okay.
Like the septum of your nose.
That's exactly right. The septum of your nose divides the nostrils. Excellent.
But you can only see it, like,
If you cut the heart in half.
Yes, you'd have to slice
in
the
one
heart.
direction.
That is correct.
Okay.
Slice the front of the heart off like they did right there. This is the. They just slice the front of the heart off, okay? And once you sliced it off like that, now you see the septum. So that's like cutting your heart top to bottom, okay? Not side to side so much as slice off the front of your heart. All right, this is what we just said about the capillaries. Oxygen and nutrients pass from the capillaries into the cells. Waste and carbon dioxide diffuse from the cells to the capillaries. That all takes place in your capillary beds. We've talked about them at the alveoli, but they're all through your body. All right. Blood contains red blood cells, which are responsible for the transportation of oxygen to the cells and carbon dioxide away from the cells to the lungs where it's exhausted, it's exhaled. That's what red blood cells do. All right. Blood also contains white blood cells that's responsible for fighting infection. Platelets, which are responsible for clotting, so you don't bleed out. And plasma, which is simply the liquid part of the blood. Blood clot formation depends on blood stasis. That just means if the blood is made up of the proper amounts of, platelets and this and this and this, if the blood is made up properly. Changes in the blood vessel walls and the blood's ability to clot. And what happens is you get a cut, your body will know that, and it will you'll have vasoconstriction. Your arteries and veins will constrict, and then the platelets clot. They aggregate or collect there, and they form a clot. Okay, like on an artery, like on a big vessel, not only will it'll constrict and pull back into the body. All right. It constricts itself off. When tissues are injured, the platelets begin to collect at the site of injury. The red blood cells, they become sticky and start to clump together. All this is helping to stop the bleeding. All right, your autonomic nervous system, we've gone over that real good. It's split into your sympathetic and parasympathetic parts. The sympathetic is your fight or flight. The parasympathetic is your rest and digest. Okay, we're typically the parasympathetic system runs us. We only kick into the sympathetic system in times of stress, okay? All right, your autonomic nervous system, it's monitoring the body's needs all through your body. There's chemoreceptors measuring chemicals. There's baroreceptors measuring pressure. There's actually, I think, one or two others, maybe more than that, but there's others, I think. It monitors your body's needs. It's adjusting your blood flow. It's speeding up your heart rate without your heart even knowing it. It may be making the heart squeeze or contract harder to eject more blood with each beat without you even knowing it. It's constricting and dilating your blood vessels, all of which you're not even knowing. Your autonomic, or in other words, automatic nervous system is doing all this. Okay? Automatically redirects blood away from, now when your sympathetic nervous system kicks in, see, it's redirecting blood away from other organs to the heart, the brain, the lungs, the kidneys. You get under stress and your stomach knots up and all. I'm pretty sure that part of the reason for that is because I know when your sympathetic nervous system kicks in, that it takes the blood from your digestive system. So your digestive system slows down, I think is what happens, and that's why you get that, one reason you get that nodding, food doesn't digest when you're worrying and nervous and stressed. okay? Because it's sending it to the heart, the brain, the lungs, the kidneys, the things that are gonna have to really have it in order to have you at peak ability, all right? It adapts, in other words. The autonomic nervous system is constantly adapting all through your body. Things are happening, changing constantly to maintain homeostasis and perfusion. Remember, homeostasis means just keeping the body on an even keel, keeping the body in the best shape possible to support life. All right, and perfusion just means blood flow to your tissues. Perfusion is the circulation of blood within an organ or tissue to meet the cell's needs. You know, for oxygen and nutrients, that's what it's bringing, and to remove the waste products. And just like we've just seen 100 times, you know, there's the artery, down to arterioles, down to the capillary beds, then we leave on the venules, get up to the veins, down to the bigger veins, and so on. All right, speed of blood flow, it's got to be fast enough to keep circulation. You got to have enough pressure to get that blood, you know, I'm standing up. It's got to get that blood straight up to my brain, but slow enough to allow these cells to exchange the oxygen and carbon dioxide and to give the cells nutrients and all of that. See, some tissues need a constant supply of blood, like the brain. You will pass out in 5 seconds or less if without a flow of oxygen to the brain. You know, there's like pressure points, you know, sometimes some types of fighting that you're taught, you know, if you compress those carotid arteries, you know, you can pass out in less than 5 seconds, okay? But others, for instance, your heart, kidneys, some of these things can last a while can last longer without, you know, a whole lot of blood. All right. All organs and organ systems depend on adequate perfusion. We know that to function properly. Death of an organ system can quickly lead to death of the patient. Your kidneys shut down, you don't tend to live much longer, you know, short of going on dialysis. If your liver stops, you know, you don't tend to live much longer, and so on. Emergency care supports adequate perfusion until the patient arrives at the hospital. That is your job. It's not your job generally to diagnose. They will even say paramedics don't diagnose. Officially, we don't diagnose. That's a doctor's job. We are to treat the symptoms to deliver the patient to the doctor in the best possible shape, to give them their best chance of survival and surviving intact as much as possible, you know, not with part of their heart dead or part of their brain dead and all. We can help them. So you are supporting adequate perfusion is basically what you're doing. Airway, breathing, circulation. You know, oh my goodness, here I'm going on multiple gunshots, the person's been hit 15 times and then run over by a tractor trailer, an EMT, come on a basic truck. It doesn't matter. You can only do the same thing you would do if they were hit one time by a bullet, okay? It's airway and breathing and circulation. You may get there and they look terrible and you can still only do the same thing. Now, I know that's easier said than done, but I come myself sometimes when I'm hearing I'm going on a bad call and I'm thinking, what am I going to do first, second? Well, I can only do, you know, and I just think I'm going to arrive, and basically I'm going to do airway, breathing, and circulation too. There may be just more things I can do than on an EMT level, but airway, breathing, and circulation. Okay? Heart requires constant supply. The brain, spinal cord, you know, we said, you know, they start to die 4 to 6 minutes. Lungs, 15 to 20. Kidneys can survive to 45. If I'm not mistaken, it's the organ of the body that can go the longest. Skeletal muscles, you know, 2 hours. I don't think you have to actually know those particular numbers. Times are based on a normal body temperature. You know, people that have been in ice water, you know, people that have been submerged in very cold water have come back to life. You know, they've been coded and they've come back without neurological deficits. In other words, with their brains intact after amazing periods of time because of how the body shuts down, almost like goes to sleep, uses very little oxygen. But under normal body temperatures, that's roughly the amount of time you've got, okay, to save certain things. Hemorrhage is just another word for bleeding, right? External bleeding, visible hemorrhage. Internal bleeding, of course, is not visible. External, it does include your nose bleeds and anything you can see. All right? With serious external bleeding, it may be difficult to tell the amount of blood loss. You can have a little bit of blood and it can make a big pool, or you can have had a lot of blood and it's soaked into the ground, okay? Body will not tolerate a blood loss greater than 20% of blood volume. All right, a woman typically is about 5 liters of blood. So the most that a woman can lose is that's 1 liter. In fact, we've done before, we've gotten strawberry soda, taken it out, poured it out, you kind of get an idea of how much. But that's what a person can lose. However, it's not so much how much they lose, it's the rate at which they lose it. You can donate blood, donate 500 milliliters of blood or so, in other words, about half of that. If you do it over 15-20 minutes, it'd be okay. I mean, you might be a little woozy, they give you the cookies, the Kool-Aid, the whatever, they give you the little booze, but be okay. But if you lost that same thing, like you just cut an artery and it just, like that, before the body has time to adjust it all to it, you can be in, worse shape. You'll react worse. Blood loss greater than 20%. So that's why, even at the expense of breathing, if the bleeding is bad enough, we stop that first. Blood looks different on different surfaces. Like say you put a little bit of blood on a hard, like linoleum floor, and just, oh my goodness, it looks like somebody got butchered here, and it really wasn't as major as it looks. But if it's poured out, if it's outside and it's in the ground, you see a red spot, but a whole liter sunk into the ground that you're not seeing. Changes in vital signs that may occur with significant blood loss. This is common sense. If you're losing blood, your heart rate's going to increase because, it's going to start to pound. The body is calling for the things that blood can do, and there's not enough blood there, so the heart's going to start to try to supply it, all right? You're going to start to breathe harder. What's that got to do with bleeding? The blood, remember, carries the oxygen to your cells. It takes away the carbon dioxide. Your brainstem is saying, well, we're having carbon dioxide build up. It's going to make you start to breathe faster, okay, more rapidly. Remember, you breathe based on the buildup of carbon dioxide, okay, rather than the lack of oxygen. A decrease in blood pressure. You may not notice that right off because the body's going to try to compensate. It's going to speed up the heart rate. It's going to make the heart contract more and eject more blood with every stroke. It's going to constrict your blood vessels, okay? A whole variety of things. But at some point, blood pressure is going to start to drop because you're bleeding. Okay?
Is it correct that that's one of the last things to go is the blood
that is
pressure?
True.
Okay.
Yeah, because your body will do everything to try to keep that blood pressure correct. It's always adjusting and maintaining homeostasis. And when it can no longer maintain the blood pressure, I mean, it's getting bad. All right. See, they'll comfortably donate 500 milliliters of blood, half that blue bottle, over 15 to 20 minutes. But it's a much shorter time, you may see hypovolemic shock. The body didn't have time to react and adjust and smooth it out. All right. You see, these are serious conditions. You see signs and symptoms of shock. If you see rapid blood loss, significant blood loss, uncontrollable bleeding, if you can't get it to stop, that's a bad sign. Poor general appearance and is calm, and so on. Hey, come on in the house. Significant mechanism of injury, even if you're not really seeing the bleeding, but if you see a significant mechanism of injury, obviously they may be bleeding on the inside. Okay. All right, arterial bleeding. Now, don't go by this. I've seen very bad bleeds be venous bleeds and all, but arterial bleeding, if the pressure is still up high enough, you typically get to the spurts. Every time the heart contracts, spurt, and then the heart contracts, spurt. That's the systolic blood pressure. All right, typically brighter red, the duller red is on the venous blood, the deoxygenated blood. All right, spurts in time with the pulse. Venous bleeding, you get the more of the steady flow, the dark red blood, but don't be sitting there trying to figure it out while they're losing blood. It doesn't matter. You stop it regardless, okay? All right, capillary bleeding, that's, like you get an abrasion, you get a scrape and blood is oozing through the skin, all right? An abrasion, that's your capillary bleeding. All right, bleeding tends to stop rather quickly within about 10 minutes, provided, we're not talking about major. So I told you about how the blood vessel, you get vasoconstriction. First, it'll constrict, and then the platelets start to clot up there. The red blood cells become sticky and clump up, and it stops the bleeding, okay? All right, Despite the efficiency of the system, it may fail in certain situations. Movement. The person keeps moving, that keeps increasing and decreasing the size of their blood vessels, and it can be a problem, okay? It mess up the clotting. Disease, such as hemophilia. Remember, that's an absence of one of the blood clotting factors in the blood, so the blood doesn't clot properly. Some medications, perhaps they take aspirin, or they take warfarin or Plavix, one of these blood thinners. You know, we say blood thinners, okay? So they bleed easier. Remember, that's why we give aspirin. That's why we give these things, is so that the blood can get around easier in the body. But the problem is that then it leaves the body easier. You know, you go to start an IV and blood goes everywhere. And whoa, 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 whoa. You know, non-medications. Removal of bandages. Don't get curious and say, I wonder if that thing has stopped bleeding. You know, take the bandage off, and then you mess up the clotting, and it starts to bleed all over again. You know, we go on trauma to the prisons, and at the prison, you know, they have an infirmary, so it's typically already bandaged. You know, when I get there, you know, they'll say this guy's got a gash, you know, 6 centimeters long and, you know, fairly deep and such. And sometimes we'll get up there to UAMS, and they'll send them to UAMS typically on that kind of trauma. And, you know, there'll be all this big bandaging and everything, and the doctor's unwinding. I'm thinking, well, I want to see this, you know, big, you know, you know, and you feel like an idiot, you know, and the doctor looks up there, stop, that's what they told me, I didn't disturb the bandage, you know, I didn't want something like that bleeding again on the way up, you know. You know, that happens, but you take it off and whoosh, you know, the blood starts to pour again, you got a problem. So we don't remove bandages, all right? Hemophilia, remember we went over that. The patient's lacking certain blood clotting factors, okay? Very rare. I think they said about 20,000 people out of 330 million or so in the United States. Bleeding can occur spontaneously. It can just start, all right? All injuries, no matter how trivial, are potentially serious. Something that to you and I, you know, oh good grief, you know, we put a thing on it, but if 2 hours later it's still bleeding, even if it's a slow bleed, that can start to be a problem, okay? Patient should be transported immediate if you run across hemophilia. I say very rare, but if you have. All right, internal bleeding. Obviously, that's just bleeding inside. All right, hard to detect right away. You know, after a little while, you need to start to notice like the hypovolemic shock. You might notice the belly becoming distended and rigid. It's not soft like it should be. Just possible conditions, stomach ulcer, you know, bleeding ulcers, peptic ulcers, lacerated liver. Perhaps they have been in a car wreck and a rib went through the liver. Ruptured spleen. The spleen is very vascular and not terribly sturdy. If it gets hit, it's very, like I said, it's very vascular. In other words, it has a lot of blood vessels, a lot of blood in the spleen. If it ruptures, you can lose a lot of blood. Broken bones, you know, we think of bones like this, but they're not. Remember, your red blood cells are made in the marrow of the bones. The bones are living things. You break the femur, you can lose 1 liter or more of blood from that one broken bone, the femur, okay? Oh, pelvic fractures, you know, it's another place. Really bleed a lot. All right, so you have a high energy mechanism of injury, even if right off you're not seeing an awful lot of blood, but you keep a high index of suspicion, all right? That car is mangled. Person's up walking around, but that doesn't mean that they're not bleeding internally, and in 10 minutes they're going to crash on you, okay? Internal bleeding is possible whenever the mechanism of injury suggests that severe forces affected the body, whether it was blunt trauma, like the patient slammed into the steering wheel, or penetrating trauma, they've got a knife in their chest. Either way, that blunt trauma, they could have tore loose stuff inside. Like I think I told you one time, I think they said about 1/3 of DOAs from motor vehicle accidents, from MVAs, are due to the aorta tearing, and these patients just bleed out, you know, almost instantly. All right, signs of injury. Mechanism for internal bleeding. So you're looking for signs of injury. DCAP, BTLS. Remember the deformities, the contusions, the abrasions, the punctures or penetrations. That's P. Your burns, tenderness, lacerations, and swelling. You know, you see these things, you know, you keep a high index of suspicion. All right? Internal bleeding is not always caused by trauma. Remember, we already talked about bleeding ulcers. GI bleeds, very common, bleeding from the colon, it's very common. Ruptured ectopic pregnancy. Remember, ectopic just means where it does not belong. Ectopic pregnancy is typically in the fallopian tube. The baby starts to develop in the fallopian tube, but as it grows, there's very little room in the fallopian tube to burst, okay? Aneurysms can be extremely serious. It can be a small aneurysm that's not, a big deal, but it can easily be fatal. Remember we talked about aneurysms, you got your perianeurysm, like the knot in the side of a tire, a weak spot in the wall of the blood vessel, it bulges out and can eventually burst. Or you can have your dissecting aneurysms, like we talked about in AAA, an abdominal aortic aneurysm, the descending aorta. You've got the 3 layers of the artery, and people with high blood pressure, like long time high blood pressure, that blood can gradually work its way and it starts to tear into the wall of the artery. It starts to actually dissect the wall of the artery. These people have a lot of pain, a tearing, sharp pain. Okay, aneurysm. All right. Nature of illness for internal bleeding. We're looking for abdominal tenderness. You're palpating the abdomen. That guarding. Is it rigid? Pain, distension. In older patients, these people don't accommodate bleeding near as well as you and I. They can't, their bodies don't react to it near as well, okay? So dizziness, faintness, weakness, because you're not getting the blood where it needs to go. You can have, GI problems. You can have blood come up this way, or it can go the other way. You can vomit it up, or it can come out the rectum, okay? All right, sensitive, still on it. All right, swelling, bleeding, distension, hematoma, okay. All right. Bleeding from any body opening. All right, we have internal bleeding. What is hematemesis?
Vomiting blood.
Vomiting blood. Hema is blood. Emesis is vomiting. Vomiting blood. Melena.
Black tarry stool.
Very good. Which is?
From upper GI bleed.
Right. So the blood is digested. All right. Okay. Hypoperfusion. What is hypoperfusion? It is
Poor perfusion.
Poor perfusion or shock,
or
the word I was
shock.
looking for, but yeah, poor perfusion. All right, shock. All right, just not getting blood to inadequate quantities to the body's tissues. So you might see changes in mental status, all right? Not getting adequate blood to the brain. Weakness, faintness, dizziness, particularly on standing, because you need that blood pressure to get blood up there. If you don't have much blood pressure, if you have poor perfusion, when you stand, you got problems. That's why we lay patients with shock, we lay them supine, so the blood can get to their brains easier. Obviously, they may be pale. They don't have that good red blood, okay? Tachycardia, thirst, nausea, vomiting, cold, moist, clammy skin, don't have proper circulation of the warm blood. So this chapter is all review. You guys already know all of this. All right, later signs of shock or hypoperfusion. Shallow, rapid breathing. Dull eyes, capillary refill more than 2 seconds, with poor perfusion. Weak, rapid pulse. Weak, because we're not getting that good, strong, beat, because we've got plenty of blood. All right, rapid because, remember the heart rate's picked up, trying to circulate what blood you do have. Decreasing blood pressure, altered level of consciousness. All right, come to your scene size up, just like all the others. Hopefully starting with dispatch, again, before you ever get out of the ambulance, quick look around. All right, let's say it's a crash, all right? Leaking fuel, energized electrical lines, okay? Violent incidents, you just had an officer here. Make sure the police are on scene. Your standard precautions, gloves, whatever. Determine, still on scene size up, what is the nature of illness or mechanism of injury? Are we going to need to immobilize the spine, the back, the spine, and the neck? All right. If everything's all right, we go right on to our primary assessment. And that's our life threats. Are there any immediate life threats? And typically before you even get to them. You're speaking to them. I'm Jonathan with Dumas EMS. What's going on today? How do they respond? And what does the largest organ in the body look like? The skin, Looks like Michael right now, warm, pink, and dry. Very unlikely they're going south in the next couple of minutes. But if it's cool, pale, and diaphoretic, then that's another story, okay? So this is your general impression, okay? And your ABCs. A general impression. I got a 45-year-old male that's speaking in 2 or 3 word bursts. That's how he answered me. I can't breathe, okay? I haven't touched it yet. I've got a pretty good idea. This guy's having trouble breathing, okay? Some respiratory. It may be cardio, may have to do with the blood, but I have a good general impression right off the bat. 45-year-old male, it's respiratory distress, it's cool, pale, and diaphoretic, airway, breathing, and circulation. Is his airway open? Yep, looks like it's open. He's breathing at such and such times a minute. Circulation, I'm checking my pulse. Your primary assessment. This is your immediate life threats, okay? Remember we said, ABCs, airway, breathing, circulation. The only time, though, that you're going to jump the gun on that, if you have life-threatening bleeding. Remember we said typically the body cannot tolerate more than 20% of its blood loss. For women, that's, about one of these. Women have about 5 of these, 5 liters. So that's about one of them. Men about 6 liters, okay? Which leads to another interesting thing. A child somewhere in the, like around the 1-year-old mark, doesn't even have this much blood. About 800 liters, okay? I say 800 milliliters, I'll get this in. Not 800 of these. 800 milliliters. 1,000 milliliters makes up one liter. So, they get a bad bleed, all right? All right, airway and breathing, this is the primary assessment. Remember, we do our ABCs in our primary assessment. Do we need to stabilize the spine? Do we have a patent, in other words, open airway? And do we have adequate breathing? And what about our circulation? Our pulse rate and quality, skin color, temp, and condition, okay? Capillary refill, all right? Then our transport decision, that's at the end of your primary assessment, okay? You've got your general impression of the patient, you've got your ABCs done. Am I gonna stay and play or load and go? All right? All right, so your assessment of the ABCs and life threats, that determines your patient priority. On the test, just automatically say you're gonna load and go. But signs that would imply rapid transport. You see rapid heart rate or rapid breathing, low blood pressure, weak pulse, clammy skin. The body is having trouble compensating. All right? Then we go to history taking. What's going on today? All right? Check out that chief complaint. And, any medical history, any particular problems, etc. Sample. Still on history taking. Remember, that's your signs and symptoms, your allergies, medications, past pertinent history, last oral intake, events leading up to this. All right? If they're unresponsive, maybe you can get some of this information from medical jewelry, a bracelet that has, that says diabetic, a necklace, okay? Maybe they carry a card in their billfold, perhaps bystanders or family. All right? You're done with your history taken. Secondary assessment. If you have time and, if they're not so serious, you may do this unseen, you may do this right to the hospital. If it's a real bad thing, you may not even have time. But this is your head to toe. This is where you get your vital signs. And head to toe assessment, okay? Assess all anatomic regions with DCAT, BTLS, look for uncontrolled bleeding, assess all 4 quadrants. Basically, and here short, soon we'll be doing our assessments, and you're gonna start at the scalp and go all the way down. I'm inspecting and palpating the scalp, I'm inspecting and palpating the ears, I'm inspecting and palpating the nose, I'm shining my light in their eyes, I'm inspecting. You're just gonna go all the way down the body saying that, okay? That's your secondary thorough assessment. All right, your vital signs. Systolic blood pressure less than 100. Of course, we don't give nitro in that case, but also you get systolic blood pressure less than 100, weak rapid pulse. This patient is probably in some trouble, okay? Cool, moist skin, pale or gray, like cyanotic, be the bluish gray color, pale, just lack of blood or lack of good blood flow. Not good signs. reassess, okay? You've done with all this, you're gonna reassess the patient every 5 minutes for an unstable patient, every 15 for a stable patient by the book, all right? Interventions, you know, you may be giving oxygen, you may be controlling bleeding, you may be providing treatment for shock, which, remember, that's oxygen in a blanket so far as, you know, oxygen control their body temperature. All right? Transport rapidly if necessary. Communication and documentation, you know, communicate anything you need that's relevant to the hospital, document everything. You heard David mention several times about court, you know, if you have to, you know, so your run report, you know, to refresh your memory. If it's not down there, you know, a year later you say, yeah, but I know I did it because I always do that. If it wasn't down there, then I'm probably not going to give you that. Standard precautions, gloves, eye protections. We're talking about bleeding here, okay? Gloves, eye protection, possibly a mask or gown. We're talking about blood, all right? Several methods, okay. All right, so controlling bleeding. Direct pressure typically controls bleeding, all right? Push down, all right? Typically gonna control, you can elevate, you know, got a bad bleed, you can push down, hold it above the level of the heart. Pressure dressings, that's what the pressure comes from. Splints is just to keep the limbs still, okay? The more you move, the more bleeding you have. And tourniquets if the direct pressure fails. When you do your bleeding station, that's how they're gonna do. You know, they're gonna say, you know, the patient's got a wound and such. You're gonna say, I'm gonna apply direct pressure. Does that control my bleeding? And the evaluator's gonna say no. So I'm applying a tourniquet. Does that control my bleeding? And I don't remember. It seems like they changed it. It's just where it's just one tourniquet. It used to be you could do a second one, but I'll have to look at the paper. I think they're just doing one now.
You go closer to the. If you do another one, is it closer or further away? I can't remember.
Well, typically now, they used to say like 2 inches above the wound and below, you know, the nearest joint. They, you know, try to save joints and all like that. But now that we've kind of found that tourniquets are not too bad, they're just going to say go high.
Go high.
Yeah, I mean, if you know, you're going to put a tourniquet on if you have a wound in an extremity. So if it's in the leg, go high. If it's in the arm, go high. The reason for that being is you have 2 bones here, and with the tourniquet, you're trying to pinch the artery against the bone. They're saying that, you know, it's possible the artery will get protected in between a couple of the 2 bones, the radius and ulna. You only have 1 bone up here, and if it's up here, it takes care of the whole arm. You know, before we were like, oh my goodness, then you might lose the arm from there down. So if the wound is here, you know, try to save the elbow for prosthetics, put it over here. Yeah, like I say, you don't lose limbs, you know, due to tourniquets if things are done right, and you know. We're not talking about now taking like a hanger, like a piece of wire, you know, and cutting, you know. We're talking about, you know, 1.25 inch wide cat tourniquet or something, you know. If it's on there for an hour, you're not going to lose the arm. By an hour, if it's bleeding that bad, you'd better in the ER, they're going to be dead, you know, or they're going to be in bad shape. All right, direct pressure, most effective way to control external bleeding, all right? Stops the flow of blood, permits the normal coagulation to occur. All right, hold uninterrupted pressure for at least 5 minutes. Pressure dressing. Remember, your dressing goes on the wound, and then the bandage is what secures the dressing, all right? So, these 4x4 sterile gauze pads, that's your dressing, and then you go put a bandage over it. Excuse me. Cover the entire dressing above and below the wound. Stretch that bandage tight enough to control bleeding, but you should still be able to palpate a distal pulse. Not, of course, if you're putting a tourniquet on, that's cutting off everything. But if you do a pressure dressing, you know, you still want to be able to have a pulse, you know, there in the arm, okay? Don't remove the dressing. Once you put it on, don't be, I wonder if it stopped, taking it off to pee, all right? It just messes it up. You leave it for the doc. Blood starts to seep through it, put some more dressings on it, wrap it again. All right? Bleeding will almost always stop when the pressure of the dressing exceeds arterial pressure, the pressure of the blood in the artery. All right, hemostatic agents, we carry those, but it's any chemical compound that slows or stops bleeding by assisting with clot formation. I think these were really, if I'm not mistaken, the Israeli Army, what really really did a lot with these. There's actually one that's called an Israeli dressing, I think, and it's actually a dressing that's impregnated with a hemostatic agent. We carry actually a powder that can just be dusted, into the wound, and it assists with the clotting. Okay. Can be used with direct pressure when direct pressure alone is ineffective. All right, tourniquet. If the patient has substantial bleeding, and there's several types of tourniquets. We have cat tourniquets over here. You guys can play with. All right. All right. Commercial tourniquet is unavailable. You can create one using a triangular bandage and a stick and rod. You're basically again, we can actually do it, but you just tie it, and then with one knot, and then you'll make a second knot on top of the first, and put a stick or something through that second knot, and then you just start twisting. All right. When you twist it to where the bleeding stops, you twist. This is your rod. You twist, and then just put it right in line here, and then tape or tie it right there. Tie that stick to the arm. Okay, and then you have a tourniquet. Don't apply the tourniquet directly over any joint. It's difficult to mash the artery there at the joint. Always place the tourniquet proximal to the injury, upstream, closer to the trunk. That just makes sense. If you're bleeding right here, we don't put the tourniquet here. It won't help. Okay, it's got to be closer to the trunk, so proximal. Make sure the tourniquet's tight and securely. Never use wire, rope, a belt if it's narrow. No narrow material. That's how tourniquets got a bad rap. One of the ways. Very narrow things. You use a piece of wire, yeah, you can do some damage. You cover that tourniquet up with a bandage when nobody knows there's a tourniquet on there, you can do some damage and stuff. Tourniquet is always left out in the open. It's wide. We tell medical personnel about it at the ER. Okay. All right. Just like with the pressure bandage, once you put the tourniquet on, don't loosen it. Leave it. Don't lose whatever progress you made by loosening it up, seeing if you're still bleeding. Yep, still is. Now you just lost whatever progress you made. You lost your clot. Air splints. These basically they go over, just like you see right there, go over the extremity, and then they're aired up, and that puts pressure. It's a pressure dressing. Okay. I don't know anyone that carries them, but they're available. All right. See, immobilized fractures act like a pressure dressing. All right. Rigid splints will help to immobilize fractures. There's rigid splints back here. Yeah, these orange things, like a rigid splint. Okay, it's padded, but inside that thing is hard. Okay, go rigid splint. And they come all different lengths and all. All right. They'll help to, of course, immobilize fractures so the bones aren't gashing, the broken ends, cutting things around, which helps to reduce your pain, prevents further damage because the broken ends of the bone are still moving around. Okay, but you always want to make sure that if you check your SMCs. All right, you got a broken arm right here. You check your sensory. What finger am I touching? Your motor. Squeeze my hand, and circulation. Do I have a radial pulse? Put your splint on. Do the same thing again. You don't want to have made the patient lose a pulse. Like you move that bone around where it's pinching off the artery, the radial artery, and now you lost blood. Put a beautiful splint on, nice and neat, and you got to the ER and the hand's dead.
Wait. So, a tourniquet won't kill your hand, but the splint could.
It's gonna. We try. Tourniquet
I mean,
is more
of course, make sure you have a pulse when you put a splint on. I just got.
I'm being extreme when I say you get that in your hand dead. It takes
okay.
a while for the hand to die.
Right.
It's not like the brain where in 4 to 6 minutes you're losing brain cells. You won't do that. And if you had to put a tourniquet, yes, you won't have a pulse. But we try to make that an extreme case. We try to have a pulse.
Okay.
Bleeding from the nose, ears, and mouth. Okay, that could be a skull fracture, facial injuries. This can be the nose drops, drugs, like cocaine and so High blood pressure will do it. Bleeding from the nose, common with high blood pressure. Digital trauma, that's a nice way of saying they're picking their nose, okay? Epistaxis, secondary to digital trauma, you know, that's the way you put it on the radio, a nosebleed due to picking his nose. Digits are your fingers. Trauma, obviously you know what that is. Epistaxis is the medical term for nosebleed. So epistaxis, secondary to digital trauma, meant they were picking their nose. All right. Can usually be controlled by pinching the nostrils together, and in the old days, you know, they said back, but we don't do that now because the blood runs down the throat. It's an irritant to the stomach. Now we have to go forward and pinch the nostrils. And I'd say Erica got to see one here. This guy, he has very high blood pressure, but he has such nosebleeds. You know, they have a thing they actually stick in his nose and they fill it up with normal saline, you know, and it's like a pressure dressing inside the nose. It mashes off his blood vessels in there. All right. Bleeding from the nose or ears following a head injury may indicate a skull fracture. May be difficult to control. I mean, how you can control, you know, it's internal, just coming out. Don't attempt to stop it. You can't. Loosely cover the bleeding site with sterile gauze, light compression with a dressing, okay? There's blood coming out his ear, it's gonna come out. I mean, you can't stop it. It's a halo test. Then you take a 4x4, they got bleeding, like say, coming out the ear or the nose, and you suspect a skull fracture. You can actually take a 4x4 and get a little bit of the blood on it, and you'll see the blood in the center, and around it you see that yellowish, greasier, you know, look. That's your cerebral spinal fluid.
Like it'll separate itself?
Yes, it will separate itself. And if you see CSF or cerebral spinal fluid, then you have a skull fracture, okay? Cerebral spinal fluid bathes the brain and the spinal column. And so you have a skull fracture at that point. All right. Keep still and quiet as possible, always. If you can keep the patient calm, you know, and the best way for you to do that is you stay calm and confident, however you're feeling, you know, yourself. Maintain their body temperature, splint any injured extremity. All right, and review. Which of the following is not a component of the cardiovascular system? Which one did you say? Oh, I just heard somebody say something, I didn't hear it exactly. B? Okay. Anybody gonna agree or disagree? That would be correct. Because remember,
Huh? No, it's pretty obvious.
you didn't know what it is? You
No,
got
I
it.
said, is that not obvious?
Oh, yeah. You know, you got your heart, that's the pump. Venules, remember, that's part of the container. And plasma is the watery part of the blood, so. That's your three parts. Pump, your blood, your container. Perfusion is most accurately defined as
C.
B. Or A. I don't know.
That's obvious. Both of those were wrong, but that's all right. Which one, Michael? Yeah. The man he gets every one of these right. Why didn't you do it on that? It looks so good on my scores if you would just do that on that. Oh, that's all right. That is true. Remember, perfusion is blood flow to the body's tissues. Good perfusion, you have good blood flow to the body's tissues. Poor perfusion, bad blood flow. Okay. Really, I guess it means good blood flow with good oxygenation, if you have good perfusion. Circulation of blood within an organ with sufficient amounts of oxygen. A man involved in a motorcycle crash has multiple abrasions and lacerations. Which of the following injury has the highest treatment priority?
D.
D.
Erica? You're on scene, it's up to you. The guy is splattered all over the road. Which one? D is correct. Spurting bright red blood, so we're suspecting, an arterial bleed. That's going to be faster than a venous bleed typically. And the thigh, we have the big femoral artery right up there. Bleeding from an artery produces bright red bleeding that spurts with the pulse. Okay, the pressure that causes the blood to spurt also makes this type of bleeding difficult to control. Which of the following sets of vital signs is least indicative of internal bleeding?
A. Actually, I don't know. I think that's right. I'm sticking with it.
What you think, Carrie?
I'm gonna say A, but I don't know, I haven't read it that great.
My blood is all pooling in my feet. Got an opinion on it, Kiera?
No, it's not gonna be A.
Hey?
It's not gonna be A.
Oh.
Well, I don't know. I'm sticking with A.
D? Notice, the highest blood pressure, so that's leading you to think that they're probably not bleeding. And the pulse rate's nice and slow. Actually, by the book, too slow. Respiratory rate's too slow. But on all of these, the pulse rate is on the border or faster. Respiratory rate, too fast on all of them. Blood pressure's low on all of them. So signs of bleeding, with the exception of that. When caring for a patient with internal bleeding, the EMT must first
D.
D.
Yeah. Those are simple. You don't have to start to think, am I going to go airway bleeding, airway bleeding? It's going to be safety first. The quickest and most effective way to control external bleeding from an extremity is
B.
Jessica? By the book, you're always going to start
That's the same.
one way.
B.
Yeah, by the book, yeah, I see where you're coming from with the tourniquet, but I'll
What
bet.
is the quickest and most effective way to control bleeding from an external?
Well-
The tourniquet, right?
Yeah, but what are you thinking about direct pressure? Are you thinking like a bandage and some Coban or? All right, you've got a bad bleed, right there. Now you don't have no more bleed. Can you put tourniquet on that fast? That was direct pressure.
You could.
Well, all right.
Well, you're
can
fast then,
demonstrate
dude.
that, I can't.
I'm about to say, you're kind of fast then, dude.
You're thinking direct pressure. Okay, I've got to put a bandage on. I've got to wrap it in Coban. I could do a tourniquet. But direct pressure is just your gloved hand over it. You see what I'm saying? It was good thinking on your part, but I bet you they're gonna say B. Now, watch me, I've done that beautiful thing, and look like an idiot now, but B.
Yeah.
I've given some beautiful, well-reasoned arguments at times, and then ding, turned the page and was, at least according to this, wrong. When applying a tourniquet to an amputated arm, the EMT should
B. Those are all ridiculous answers. Those are all so stupid. Make sure you cover the tourniquet with a sterile bandage.
Well, he sounds mighty cocky. You gonna agree with him, Carrie, or you think he's wrong?
I mean, it just got amputated?
It doesn't say, it just says amputated.
I'm agreeing with Blake. I mean, the rest of them.
Those are all.
We literally just talked about this.
You're not gonna put it on the joint. I'll miss that.
That's right, we're not gonna put a tourniquet on the joint, or over the joint, as they say. We're not gonna cover the tourniquet with a bandage, because then, that might be missed. We're not gonna use rope, nothing thin. So, B. A 70-year-old man is experiencing a severe nosebleed. When you arrive, you find him leaning over a basin, which contains an impressive amount of blood. Has a history of coronary artery disease, diabetes, and migraine headaches. Blood pressure is 180 over 100. Heart rate's 100 beats a minute. Which of the following is the most likely contributing factor to his nosebleed?
Yeah, A.
What you thinking, Tammy? I agree. It is. High blood pressure. When caring for a patient with severe epistaxis, the most effective way to prevent aspiration of blood is to
B. D just doesn't even make any sense.
maybe if you have a
Hold
winch or
on.
something,
Yeah.
tie him back one way and crank his head down the other. I agree. B. And last, controlling internal bleeding requires
D.
Erica, you gonna agree or disagree?
I mean, it can be D and D.
Yeah, it could be either, but I don't think
Tammy?
But I
applying.
can't do B, so I'm sure it would be D.
I don't know how to apply a tourniquet for internal bleeding.
Right, so big is the big.
I think it's
D?
D, cause like I don't do surgery in a hospital.
B.
I'm gonna agree with, what are you saying, Erica?
Whichever one's right.
All right, which one's right? Let me rephrase the question.
What's in my scope?
Does it mean what we can do or what?
What is in our scope?
Well, cause it says.
If it doesn't
controlling
give you the
internal-
information, then they consider you didn't need it. So controlling internal bleeding requires, and you ladies would be right.
Yeah, you say that. I'm waiting for the what? No.
You can't control it in the field. You can't control it if you drive slow. You can't control it if you use tourniquets. You can't control it with direct pressure. You can't control internal bleeding, okay? That requires surgery. It's out of an EMT scope of practice unless you're Haley Powell.
Huh?
And her patient ended up in the
can't-
hospital with an infection. All right, take a break.
Let me send